The presentation will proceed by outlining key findings and policy recommendations derived from my research, with a focus on addressing racial health inequities in urban development. This dissertation integrates several public health competencies outlined by the Doctorate of Public Health DrPH program, including data and analysis, leadership, management and governance, and policy and programs. Each competency is integral to the study's design and its potential to influence real-world public health practice. Data analysis. This study employs a quantitative approach using pre-existing data sets, including those from the CDC, the U.S. Census, and various investment databases. It quantitatively analyzes the relationship between gentrification, displacement, and health disparities. In the area of leadership management and governance, the findings aim to communicate public health data to diverse stakeholders, including urban planners, real estate developers, community organizations, and policymakers. This is so you can promote strategies that balance urban development with public health goals. And last but not least, policy and programs. This research culminates in policy recommendations that highlight the importance of integrating health equity into real estate development. Such policies are essential for mitigating displacement and fostering environments conducive to health environment and improvement. On the next three following slides, we are introducing important key terms that are critical to understanding the scope and depth of this study. These terms will help guide us through the research, focusing on essential aspects of gentrification, displacement, investment patterns, and racial mortality disparities. I will read the terms to ensure you are acquainted with the following acronyms and definitions, as it might be hard to follow. So I need you guys to be a smart class today. These terms are fundamental for understanding the context of the study and how they relate to the findings. Metropolitan statistical areas, also known as MSAs, are regions with urban cores, characterized by high population density and strong economic ties. Census tracts are small, fixed segments that are established by the U.S. Census Bureau for data examination. Life expectancy is the average age a person can expect to live, but this study, our study, uses racial mortality data for a more granular comparison. Further concepts and terms that you guys should know. Gentrification, a low-income area renovated by affluent individuals, increasing poverty values and displacing poorer residents. Displacement, where residents can no longer afford to live in an area due to rising property values. A mortgage, some of you in here have that. A loan secured by real property, used as investment data through the Home Mortgage Disclosure Act, also known as HMDA, for the Racial Bias Index and Contemporary Mortgage Disinvestment Measure, Redlining. And last but not least, the Federal Financial Institution Examination Council, also known as the FFIEC, a government agency regulating banks to ensure compliance with fair lending practices. The Community Reinvestment Act, also known as the CRA, a law encouraging banks to invest in underserved communities. Community Development Financial Institutions, to connect with the people here locally, that's like a list, Milwaukee, known as a CDFI, offers services and funding to underserved communities. Rebounding neighborhoods, areas experiencing significant improvement after a period of decline. And fallen stars, which is a favorite term of mine, which is once prosperous neighborhoods that experience economic decline. The central research question of this dissertation is, what is the relationship between investment patterns, gentrification, displacement, and racial mortality disparities in the United States metros, like mentioned before, with an additional focus on Milwaukee census tracts? The dissertation addresses three primary objectives: to examine and understand the relationship between neighborhood characteristics, such as housing investment, gentrification, and socioeconomic status, as it relates to mortality rates across U.S. metro areas, to analyze and assess the associations between investment patterns, such as mortgage lending, CDFI funding and investments, and small business lending as it relates to racial mortality disparities. And last but not least, to inform and propose policy recommendations aimed at leveraging health-oriented real estate development as a public health strategy to reduce structural inequities and improve health outcomes. Neighborhood conditions are significant determinants of health outcomes. The physical environment, housing quality, and access to essential services directly influence community health and life expectancy. In Milwaukee, for example, the life expectancy gap between white and Black individuals is 12.7 years. That reflects a profound racial health disparity that is tied to factors such as historical segregation and contemporary patterns of disinvestment in this community. These disparities are exacerbated by factors such as land use, socioeconomic status, and access to resources, which are often concentrated in disadvantaged areas. Vulnerable groups, such as older adults, women, and children, are particularly at risk and in higher risk in neighborhoods with suboptimal infrastructure, pollution, and limited healthcare access. This highlights the long-term health impact of disinvestment in marginalized and underserved communities. Displacement is a significant urban issue, and while gentrification is often seen as a primary driver, poverty is a more frequent cause of displacement. According to the City Observatory, displacement driven by poverty leads to property abandonment and blight, which in turn impacts the health and safety of communities. Blight refers to deteriorated properties that pose risks to residents, contributing to higher rates of crime, mental health challenges, and environmental hazards. The social and economic consequences of displacement extend far beyond the loss of housing, as vacant properties inhibit economic development and impose physical burdens on municipalities for remediation and community stabilization efforts. As we all know, and maybe some of you do not know, gentrification is a multifaceted process with both positive and negative effects and impacts on communities. While it can result in infrastructure improvements, including public spaces, reduced crime, and even enhanced services, it also raises concerns about the displacement of low-income residents and the erosion of long-established community ties and social connectedness. As neighborhoods become more attractive, original residents, often from minority and economically disadvantaged backgrounds like myself, face displacement due to rising rents and property values. This disruption exacerbates health inequities as displaced individuals experience economic instability, stress, and severed social networks, leading to a long-term negative health outcomes despite some of the short-term neighborhood improvements that they may see. Now, gentrification can be looked at multiple scales. It occurs at different scales and each have a distinct implication for local communities. For example, from a large-scale standpoint, it affects multiple districts with major urban areas, leading to widespread demographic shifts and transformation of the urban environment. On a smaller scale, gentrification involves localized investments that lead to shifts in housing values and demographic composition within inner city neighborhoods. From a state standpoint, gentrification, often driven by government initiatives, is designed to facilitate urban growth, but these efforts can lead to displacement of low-income communities unless accompanied by protective policies. Redlining is a historical practice that continues to affect urban communities today. In the 1930s, the Homeowners Loan Corporation, also known as HOLC, used the maps that deemed minority neighborhoods as high risk and thereby prevented them from assessing mortgage loans. The enduring impact of redlining is seen in present-day urban areas, where segregation and disinvestment have led to persistent poverty, limited home ownership, and unequal access to quality housing and healthcare. Government policies have played a central role in fostering housing segregation. Federal policies promoted suburban growth while allowing for the destruction of urban housing, particularly in minority-dominated neighborhoods and underserved communities. Urban renewal projects targeted Black communities for demolition, displacing thousands of residents and creating long-lasting economic and health disparities. And we see that even in today's society. Post-World War II, Urban transformation saw the rise of suburbanization, facilitated by federal policies that provided mortgage subsidies for white families while leaving urban areas, particularly, once again, those with high minority populations, to deteriorate. The decline of industrial cities contributed to economic disinvestment, exacerbating poverty and segregation. These changes created an environment where Black families and marginalized communities were systemically excluded from economic opportunities and health benefits. In 1970, at least 12% of the U.S. population lived below the poverty line, with Black individuals experiencing a poverty rate 3 times higher than that of white individuals. Factors strongly associated with poverty included households without a male head, large family sizes, a minority status, unemployment, and lack of education. Structural economic and social issues were recognized as primary causes of poverty. Public housing contributed to the concentration of poverty in cities like Columbus, Ohio, particularly, once again, impacting Black communities more than white communities. Public housing accommodated at-risk populations and influenced the surrounding housing market, which worsened poverty concentration, though. Particularly in the northern Midwest and Northeast, the concentration of poverty grew mainly in central city districts. This was marked by a significant increase in the population of areas with extremely high poverty. Concentrated poverty dropped dramatically in the 1900s as impoverished individuals spread more widely throughout metro areas and became more physically separated from one another. However, this deconcentration mainly occurred among underprivileged groups, maintaining spatial distance from the wealthy. During the Great Recession, government housing subsidies and vouchers helped limit rental affordability concerns for low-income households. Between 2005 and 2009, 1 in 4 areas in the United States had poverty rates exceeding 20%. African Americans and Latinos were hit the hardest by the Great Recession, which also, once again, increased poverty rates and created financial uncertainty for these groups. Existing disparities in housing, education, and employment worsened the situation, and we see that in present-day society. According to a Time article and data from the New York University Health Cities Health Dashboard, life expectancy in the United States is 78.6 years. The data suggests that residents of 56 of the 500 largest cities in the U.S. may expect to live at least 20 years less than residents of other communities, even when living just a few blocks or miles apart from one another. With variations in income, race, ethnicity, and access to healthcare, larger cities like Chicago, Washington, D.C., and New York City can show disparities in life expectancy between neighborhoods exceeding 27 years, as you can see here. In Fishers, Indiana, residents may have a life expectancy of 2.5 years shorter compared to those in other parts of the city. And meanwhile, there is a 17-year difference in life expectancy between Fishers, Indiana, and Martindale, Brightwood, Indiana, which is adjacent to these other cities across the United States. Data shows that cities with the most significant differences in life expectancy across the country also experience the highest levels of segregation. Communities with higher levels of racial and economic segregation have notably higher rates of premature mortality. These rates are closely linked to disparities in diabetes, mortality between Black and white populations in major U.S. cities. Marginalized populations and those who are underserved face various challenges, including disparities in unemployment, high housing costs, elevated crime, violence rates, and poverty. These issues are less prevalent in communities where white individuals make up the majority. The number of epidemic poverty tracks globally and in the Milwaukee metropolitan area increased between 1970 and 2010. Like I mentioned earlier, epidemic poverty tracks are widespread areas where at least 20% of the population lives below the federal poverty line. These areas are identified using census tracts or block numbering areas, also known as BNAs. In 1970, there were 19 poverty tracts in America's poorest urban neighborhoods. This number then increased to 88 in 2020, with the addition of 74 more. The study defined fallen stars, like I mentioned before, as areas with poverty rates below 15% that now have rates exceeding 30%. Rebounding neighborhoods experience either significant improvements or little change following a period of deterioration and depreciation. Data shows that historical conditions and the distribution of people and businesses in an area are essential for understanding context, developing effective policies, informing investment decisions, and predicting future trends. Our past conditions often influence how well an area is growing in the present, suggesting that growth is also determined by history. Although we know that gentrification, displacement, and investment patterns interact in complex ways and could affect racial mortality rates in the United States, further study is required to fully grasp this intricate interaction and relationship. Understanding the specific characteristics of this association could help public health experts and legislators address broader social and health issues in local areas by providing insightful analysis. This research was guided by the socio-ecological model, which emphasizes the interconnectedness of individual health and structural determinants such as neighborhood conditions, economic opportunities, and resource access. By viewing health disparities through this lens, we recognize that health outcomes were not solely determined by individual behaviors, but were shaped by interrelated systems at various levels in society. Understanding systems thinking was essential because health inequities were driven by factors ranging from individual choices to structural policies that shape neighborhood conditions. This model reinforced the need for multi-level interventions to address these disparities going forward. This study adopted a quantitative design with two case studies. A national analysis, and this part of the study examined the top 50 U.S. metro statistical areas, MSAs, as of 2020, using data sets from CDC Wonder and other public health and economic sources. For those who don't know what CDC Wonder is, it is a wide-ranging online data for epidemiologic research and is an online platform provided by the Center for Disease Control and Prevention, also known as the CDC. It allows users to access a comprehensive database of public health information, including mortality, morbidity, birth and disease statistics, and allows researchers like myself and others to analyze and visualize trends in public health. It provided a broader perspective on how national trends in investment patterns and displacement correlated with racial mortality disparities. For the local analysis for Milwaukee, we focused this case study, which used census tract level data to provide a more localized understanding of how neighborhood conditions affected racial health disparities within the context of urban development. These case studies utilize robust, publicly available data to analyze the relationship between urban changes and racial mortality disparities. This study employed several key variables to measure the impact of neighborhood changes on health disparities. For the outcome variable, the primary outcome was the Black to white mortality rate ratio, also known as MRR, and the study examined the change in the Black to white mortality rate ratio between 2006 to 2010 and 2016 to 2020 to assess how gentrification, displacement, and economic investment impacted racial mortality disparities over time. Additionally, the Black to white mortality rate ratio for 2016 to 2020 was used to assess more recent disparities in racial health outcomes. For the displacement measures, the study tracked changes in Black and Hispanic populations to assess the impact of displacement on health disparities and racial mortality disparities. Displacement was a key driver of health inequities, and the study examined how population shifts influenced health outcomes in urban neighborhoods, particularly in Milwaukee, where displacement and gentrification are seen to be prominent. Economic investment. The study analyzed investment patterns from sources such as I mentioned before, the FFIEC, CDFI, and HMDA to examine their relationship with racial mortality disparities. These investments were measured at both the MSA and census tract levels, with a particular focus on the effectiveness of CDFI investments in supporting marginalized communities more granularly. The HMDA Racial Bias Index and redlining measures helped assess the ongoing impact of lending bias and contemporary mortgage disinvestment in certain neighborhoods, which continues to contribute to mortality disparities and health disparities overall. For the gentrification indicators, gentrification was measured using the Composite Gentrification Index, which included changes in median home value and median rent, changes in household income, and the percentage of college-educated residents. These measures assessed the extent to which neighborhoods underwent gentrification and how this process impacted racial mortality disparities over time, particularly, once again, for Black and Hispanic populations. To analyze these relationships, this study employed an ordinary least squares OLS regression using STATA, a standard statistical technique that estimated the relationships between independent variables and health outcomes, adjusting for potential confounders. For the MSA level analysis, the broader national trends in investment and displacement were examined using MSA level data to understand the metropolitan scale impact on racial mortality disparities. For the census tract level analysis, the more localized analysis focused on Milwaukee, offering insights to how neighborhood level dynamics contributed to racial mortality disparities at the census tract level, which is a more granular level than the MSA level. Both methods enabled a detailed understanding of the complex relationship at both broader and more localized levels. And it is also important to note that the unadjusted models examine the relationship of a single independent variable and the dependent variable and adjusted models controlling for demographics and structural factors. So, take a good look at this. It's a lot of numbers. I'm going to break it down, and then the following slides will not look like this so that we can understand the data more granularly. At the MSA level, the analysis revealed limited significant associations between gentrification, displacement, economic investment, and changes in the Black to white mortality rate ratio from 2016 to 2010 and to 2006 to 2010, and to 2016 to 2020. It is important to note that displacement is a percentage of Black and Hispanic population loss, and it's a positive is a loss, as that is not intuitive in this data and presentation. The odds ratio of denial of mortgage applications for Blacks as compared to white applicants is the HMDA Racial Bias Index. Black displacement. While there was a small increase in mortality disparities in unadjusted models, this association became non-significant after adjusting for demographic and structural factors. For Hispanic displacement, while the unadjusted model showed a significant decrease in racial mortality disparities, the association became non-significant after adjusting for structural and demographic factors. Investment measures for FFIEC and CDFI. These investment measures show no statistically significant relationships with mortality disparities, suggesting that large-scale regional investments may not have been sufficient in addressing racial mortality disparities. And we see the same for the HMDA Racial Bias Index data as well. For the Gentrification Index, similar to investments and all the factors that contribute to the Gentrification Index as a whole as variables, the Gentrification Index showed no significant association, as the variables did as well independently, indicating that while gentrification may have impacted neighborhoods, it did not consistently translate into measurable improvements in racial mortality disparities at the metropolitan scale, and we weren't able to discover an association. Now, this is better for your eyes now. Further examining the most recent Black to white mortality rate ratios from 2016 to 2020 at the MSA level revealed some key findings. For Black displacement, while the unadjusted model showed a significant association between Black population loss and racial mortality disparities, This relationship became non-significant after adjusting for structural and demographic factors. For Hispanic displacement, initially, while the unadjusted model showed a small but not significant decrease in racial mortality disparities, this association reversed and remained non-significant after adjusting for demographic and structural factors. For CDFI investments, these investments showed significance in the unadjusted model, but their impact diminished after adjustment. This suggests that while CDFIs may have had a positive influence on health outcomes, the effect may have been more complex and dependent on other factors. Same with the FFIEC investment data as well. For the HMDA Racial Bias Index, mortgage lending bias was evident, with marginal significance in the adjusted models, highlighting the importance of addressing discriminatory lending practices to reduce racial mortality disparities. And with gentrification, the relationship between gentrification and mortality disparities remained non-significant, reinforcing the findings that gentrification is complex, at least at the MSA level, and did not consistently improve racial mortality disparities. Now we're on to the census tract level with the Milwaukee study, which is the second aim. At this level, the analysis revealed several statistically significant associations with changes in mortality disparities. Black and Hispanic population for displacement, there was a strong negative association with mortality disparities, suggesting that displacement, particularly in marginalized communities, may have led to a reduction in racial mortality disparities, though this was likely driven by population shifts. For the HMDA redlining showed a strong positive relationship with racial mortality disparities, underscoring the long-lasting effects of disinvestment of contemporary mortgage loans and lending on racial mortality disparities. For gentrification, initially, it was negatively associated with racial mortality disparities, but after adjusting the model for demographic and structural factors, the relationship reversed, showing a strong positive association. This suggests that while gentrification may have initially appeared to improve neighborhood conditions, it may have exacerbated racial health disparities and mortality rates due to displacement and loss of community stability. And last but not least, the second part of the second aim for the Milwaukee census tract. When examining the most recent mortality rate ratios from 2016 to 2020 in Milwaukee, it also reveals significant results. Black and Hispanic displacement showed a negative association with mortality disparities and remained significant, indicating that displacement may have contributed to a reduction in health disparities, but this had to be interpreted with caution due to potential confounding factors. FFIEC investment. Investment from the FFIEC was significantly associated with reducing racial mortality disparities at the census tract level, emphasizing the importance of targeted financial investments in low-income neighborhoods and in society as a whole. Redlining remained a strong predictor of racial mortality disparities, reinforcing the need for interventions to address disinvestment in mortgage loans and lending practices. And last but not least, gentrification once again. The relationship between gentrification and racial mortality disparities remains significant in adjusted models, suggesting that while gentrification may have led to improved neighborhood infrastructure, its effects on racial mortality disparities were detrimental, and it also might be correlated to displacement. Now, while this study provided valuable insights, it was not without limitations. For data availability, there was some incomplete or suppressed mortality data, limiting the availability to analyze certain regions comprehensively. For example, as you probably have noticed, in the first aim, Black displacement and Hispanic displacement were separated. In the second aim, I grouped them together. The reason for that is that as you get more granular, you don't have enough population data for some of these demographics. So you have to couple them together to make sure that you have a more conclusive understanding of the relationship that you're trying to assess and examine. For measurement challenges, the gentrification index served as a useful proxy to bunch all the variables together as one and measure it in the adjusted model. But as we know, it does not fully capture all dimensions of gentrification, because gentrification is just complex in general. So the nuances of economic mobility and social dislocation are not included in that measure as a whole and using that proxy. For confounding factors, other variables such as housing policies and migration patterns, specifically when you think about Hispanic populations, they may have influenced the results, but were not fully accounted for in this study because it's a quantitative study and not a qualitative study. There are temporal limitations, meaning that the study spanned nearly 20 years, but the long-term effects, as we know historically, of neighborhood changes may have extended beyond this period of what this study actually measured. So future research could benefit from more frequent longitudinal data, and additional methodological challenges include spatial patterns that affected mortality estimates, and like I mentioned before, lack of qualitative insights, or what I like to refer to as lived experience, to speak to this study, meaning that the community's perspective on social connectedness and housing stability are not captured in this study. Displacement has stronger effects at the census tract level, particularly in Milwaukee, where local dynamics of neighborhood change were more visible. At the MSA level, displacement appeared less impactful due to broader, more diffused patterns. Although population shifts may have reduced mortality disparities in the short term, like I mentioned in my lit review and intro, displaced individuals often relocate to areas with fewer resources, which creates long-term health challenges for their access to care, housing, and community resources and support. And that's really due to social connectedness, but being disconnected when you are a demographic that's moving into an area where you're not the majority of the population there. These ongoing health challenges highlight the need for policies to ensure that displaced communities receive adequate support in their new environments if they choose to leave on their own and or if they have been displaced due to things that are out of their control. Economic investments played a critical role in shaping racial mortality disparities. At the MSA level, investments from the FFIEC and CDFI did not significantly affect mortality disparities, suggesting that broad regional investments may not have been sufficient in addressing the needs of marginalized communities, and or future studies need to do more of a granular approach to looking at how investment flows. At the census tract level, redlining, once again, which is contemporary mortgage disinvestment, was identified as a significant factor in racial mortality disparities, underscoring the importance of targeted investment in disinvested neighborhoods. Gentrification, once again, presented a complex picture. Gentrification is complex. Initially, it appeared to reduce health disparities and racial mortality disparities due to improvements in infrastructure and reduced crime. However, after adjusting for structural factors, the association reversed, showing an increase in disparities due to displacement. The local impact of gentrification was more significant at the census tract level than at the MSA level, reinforcing the need to understand the local variations in the gentrification process and its effects on racial mortality disparities and health outcomes as a whole. Displacement was often the key driver of these adverse effects and policies, and had to focus on preventing displacement while ensuring that marginalized communities benefit from neighborhood improvements is something that society needs to look at more closely. The findings from this research have several important policy implications for society. Community wealth building, a public health intervention should strengthen community wealth, ensuring that residents benefit from urban redevelopment without being displaced if they do not want to be displaced and or move from their community. This can be achieved through initiatives such as community land trusts, tenant protections, and affordable housing programs. Housing is health equity, whether that's the quality of housing, the affordability of housing, and access to neighborhood opportunities, and it must be viewed as fundamental public health issues. Addressing these disparities can significantly improve racial mortality disparities and health equity across racial and socioeconomic lines. And real estate development, it has to start being looked at as a tool to improve health. Real estate development must prioritize health equity to create healthier environments that benefit all residents, particularly those from marginalized, relegated, and underserved communities. As I mentioned before, Housing quality is a critical determinant of health. Poor housing conditions, such as overcrowding and exposure to environmental toxins, significantly impacts chronic health issues like asthma, cardiovascular diseases, and mental health disorders, particularly, once again, in those communities that are marginalized, relegated, and underserved. This dissertation emphasizes how gentrification, while improving neighborhood infrastructure to a certain scale, often fails to address housing quality for existing residents, which exacerbates health disparities by increasing housing instability and displacement for residents. Notably, displacement among Black populations in Milwaukee was linked to worsening racial mortality disparities before adjustment in the MSA analysis. This underscores the long-term impact of housing instability. And to foster health equity, housing policies must prioritize both affordable housing and quality living conditions to mitigate these health risks in the future. Community engagement is essential to ensure that urban real estate development benefits long-standing residents and prevents displacement going forward. Participatory planning methods such as charrettes, and those are community settings where municipalities help host community sessions and dialogues led by various NGOs, nonprofit organizations, academic institutions, real estate developers come in, architects come in, and it's a community session to really sit down and see how does a community need to be designed, right? So you go through various potential projects and real estate development projects in the charrette. And by the time a charrette is done, because it could go on from 3 days to a week, as I've been a part of them, you get to a consensus. And it's a collaborative process that allows input from the community so that they are involved in the real estate development process. In Milwaukee, the research underscores the need for community input like a charrette and other mechanisms to mitigate the health risks of displacement. Home ownership programs, when integrated into redevelopment projects, provide long-term stability, reduce mental health stress, and increase social resources within communities. Public health policies must emphasize community-driven redevelopment, ensuring that urban transformation promotes health equity and economic mobility long-term. Like mentioned before, community wealth building. It focuses on creating local economic opportunities by investing in community assets and local businesses, ensuring that the benefits of urban development stay within the community and for those who want to live within their community. The research supports that anchor institutions, one like a medical college of Wisconsin, such as universities and local hospitals, can drive investment in local infrastructure, leading to economic inclusion and community resilience. This approach mirrors the success of a study that was done in Preston, UK, where local investment through community wealth building resulted in improved mental health and economic mobility. Life satisfaction improved by 9%, and then there was an 11% increase in median wages over time. In Milwaukee, a similar model can reduce health disparities by promoting sustainable development that benefits all residents, especially those in underserved and relegated communities. Urban development, as I like to call it, or urban real estate development, must prioritize health in addition to economic growth. Policies that incentivize health-focused and/or oriented real estate development, such as those promoting green spaces, affordable housing, and healthcare infrastructure, are crucial for creating equitable urban environments. The research findings suggest that transit-oriented development, known as TOD projects, can promote active transportation and environmental sustainability, that contributes to better health outcomes and racial mortality disparities over time. Additionally, displacement protections, such as rent control and tenant protections, must accompany urban renewal projects to ensure that low-income communities are not displaced if they would not want to be displaced as neighborhoods improve. These policies will help reduce racial mortality disparities over time and the immediate health disparities, and ensure that gentrification actually benefits all and not the newcomers into a community. Community benefit agreements such as CBAs, or I should say referred to as CBAs, are a tool to ensure that the benefits of urban development projects extend to local communities, particularly those at risk of displacement. CBAs typically include provisions for affordable housing so that we ensure that low-income residents are not displaced, local hiring and living wages so that we create economic opportunities for community members, And environmental improvements, such as green spaces and public health infrastructure, are some of the things that you can see in the CBA. For instance, the LA Live CBA ensured that a large-scale development provided affordable housing and local job creation, directly benefiting displaced communities. And to even add on to that, the Hispanic community was very influential in making sure that they advocated for this CBA in Los Angeles to happen and move forward. The findings from this dissertation show that the need for similar CBAs in Milwaukee are necessary to ensure community wealth building and prevention of displacement as neighborhoods improve. And even more so, it's also needed across the United States of America as a whole continuously. This research highlights the need to address root causes of racial mortality disparities rather than focusing solely on economic investments. The relationship between neighborhood change and health is complex, and it requires a comprehensive approach that considers historical context and systemic inequities collectively. Future research should investigate how financial strategies through organizations that are like CDFIs can help prevent displacement and support community stability. It is essential to understand which policies such as rent control, tenant protections, and inclusionary zoning with density bonuses are most effective in preventing displacement and ensuring health equity. Examining zoning reforms that consider public health, including access to healthcare services and healthy food, can lead to more healthy-oriented real estate development projects. Long-term studies that track the health outcomes of displaced populations can provide valuable insights into the lasting effects of displacement and help create better interventions for the future. Investigating innovative development models like community land trusts and cooperative housing can offer ways to balance economic growth and social equity, and those studies are actually taking place currently. This can help reduce disparities and improve public health outcomes. Additionally, further research is needed on the role of commercial real estate development, such as grocery stores and healthcare facilities, and its impact on racial mortality disparities and public health outcomes. In conclusion, this study highlights the need for policy and practice changes that address the underlying causes of racial mortality disparities and the differences, rather than merely making general economic investments, which may not yield improved health outcomes. While it demonstrates connections between gentrification, displacement, and economic investment as it relates to racial mortality disparities, it does not establish that one causes the other. Further research is necessary to enhance our measurement of these issues, incorporate qualitative data and quantitative data collectively, and understand the long-term impacts of enacted policies. Policies shape how issues like displacement and gentrification affect racial mortality disparities among races. Strategic interventions, such as comprehensive community business agreements or standardized health criteria that incentivizes low-income housing tax credits on a state level for developers interested in health-oriented development, can ensure that everyone benefits from development without increasing these disparities over time. By prioritizing stability, targeted health efforts, and equitable growth, policymakers, public health practitioners, real estate developers, architects, urban planners, and everyone alike can create healthier and more inclusive communities. As I stand before you, I'm reminded of the words from Jeremiah 29:11. For I know the plans I have for you, plans to prosper you and not to harm you, plans to give you hope in the future. Walking in purpose means embracing obedience to God's calling, trusting that despite the challenges, there's always light at the end of the journey, and that light is here. I want to express my heartfelt gratitude to those who have supported me throughout this journey. My committee members, Dr. Kirsten Beyer, Dr. Stacy Young, Dr. Kirky Harris, and Kaylin Haywood Sr., who's an honorary member of my committee and who was also my site preceptor for my applied practice experience. Your leadership and support have been invaluable. Dr. Yu Hong and the Geospatial Epidemiology and Outcomes Shared Resource Team, Dan Sanfilippo, who's in the room, and Kirsten Ertl, your expertise and guidance were essential for this research, and I thank you. The Medical College of Wisconsin, the Institute for Health and Humanity, the Doctor of Public Health Program, and the Health Resources Service Administration, also known as HRSA, for providing me the platform to fulfill my purpose. As most may not know, half of my tuition was paid for through HRSA for this 3-year process. The Wisconsin Department of Health Services, also known as DHS, and the Medical College of Wisconsin Breast Cancer Race and Place Project led by Dr. Kirsten Beyer for the data that shaped this study. Thank you. To my cohort, the caucus, specifically Jean and Jasmine, my family and friends, your unwavering support and belief in me has been a constant source of my strength. This journey has been one of faith and perseverance. To the right of me is my first assistant principal, the first assistant principal of Craig Montessori School in the city of Milwaukee, who passed yesterday from cancer. As a child, she had breast cancer when we were kids. And it came back and it moved to her liver. She passed yesterday when she was being moved to hospice. I got to see her. One of my former teachers, his wife, reached out to me on Monday and said, Miss Michelle Butts is in care and will be moving to hospice if you want to come see her. I was finalizing my slides and I stopped everything to go see her because tomorrow's not promised. And as you can see, tomorrow's not promised. She passed at 77. And God bless you, ma'am. Thank you for your efforts. Thank you for helping shape the young Black boys and girls of the city of Milwaukee. As a Black girl from the north side of Milwaukee, I'm proud to say that the marathon continues. And thank you to all who have been a part of my educational journey through Milwaukee Public Schools through and through. I'm proud. To God be the glory. Thank you.